So if I can welcome you to the Tees Valley CCG Primary Care Commissioning Committee meeting. Obviously, this is a regular business meeting of the CCG held in public. So thank you to the members of the public that have been able to join us today. Because obviously of the current restrictions, we're still holding meetings virtually rather than at our local venue at North Ormsby. As you've seen the video, the meeting is recorded, so it will be available publicly as well. To allow smooth running of the meeting, the normal protocols apply. I won't go through them all. I think the only thing I would say is if you've got a question, if you can use the hand function to pop your hand up. But if I miss it, please feel free to shout up and I'll catch you. In terms, if there is any technical issues, I think Michelle will jump on and chair. Is Michelle on? Yeah, lovely. I've got her. Yeah, lovely. So I'm not expecting any technical things, but the delivery people might come, Michelle. So I'll hopefully somebody else in the house might answer the door for a change. So we've been we were advised actually that a couple of members of the public wanted to attend, but I can't see them on the call, so I won't announce them at this stage. But if they join us later, that's absolutely fine. There'll be an opportunity at the end of the meeting to ask any questions if anybody wants to ask any questions, and we'll do our best to answer them. We haven't been advised of any questions in advance. We've got apologies from Ali Tamasibi, Dr. Janet Walker, Kelly Wilson and David Steele, and Sue Greaves as well, unfortunately can't be with us today. So, but we are quorate. So with that, I'll press on. I haven't had any notification of any items of any other business. So I don't know if anybody wants to raise any issues of any other business now. No, everybody shaking their heads, lovely. In terms of declarations of interest, item 61, the Mackenzie Group practice, the potential permanent branch closure application. There may be an actual or perceived conflict of interest in receiving and discussing the contents of this report by members of the committee if they're a patient or employee of the Mackenzie Group practice. So conflicted members can get the report, but they shouldn't be involved in the discussions. And there's been no further declarations of interest advised other than the ones that are already noted on the log. So anybody got any declarations of interest that they want to raise? Can't see any hands going up. No, lovely. Okay, that's great. So if we can move to item 58, which is minutes of the previous meeting, which was way back in October, to confirm that the minutes are a true record of that meeting. So can members confirm that it's a true record? People that were there? Yeah, lots of heads.
Yes.
Yeah, lovely. That's great. Thank you, David. And then in terms of the action log, there's one item open on page 17, but that's already on the agenda. So we'll address that as part of the agenda, if that's okay. So with that, I'm going to move on to item 60, which is the Cotham surgery, the CQC inspection report, and Culvey is going to take us through that.
Thank you, Chair.
Thank you, Culvey.
On the 7th of September 2021, Cotham Surgery announced an inspection from CQC with the report published on the 14th of October 2021, rating the practice as requires improvement overall. The CQC found the practice in breach of Health and Social Care Act 2008 and have issued the practice with a warning notice in relation to Regulation 12, Safe Care and Treatment, and a requirement notice, Regulation 17, Good Governance. A review of the draft report was carried out by NHS England and Improvement Assistant Medical Director, who provided a risk rating of 12. The main areas of the breach are failure to ensure clinical and healthcare professionals are registered, failure to ensure any healthcare professionals providing services have access to and/or the opportunity to undertake training with a view to maintaining their competence, failure to have effective systems of clinical governance, and failure to comply with all relevant legislation and have regard for relevant guidance. The committee is asked to approve the issuing of a breach notice in accordance with Regulations 12 and 17. Thank you.
Thanks, Colby. I'll open it up to the floor to ask if anybody's got any questions. It was pretty somber reading through the report. It's such a shame that the improvements that were made hadn't sustained from inspection to inspection. Has anybody got any questions for Colby in terms of any of the detail?
I've got my hand up.
Lovely, thanks, David. Yeah, over to you.
It's just a very minor point, really, but I was just wondering in Appendix 3, as it's quite a formal letter and breach notice, whether it should include the fact a date for returning one copy to Culvey and retaining a second copy, whether that should be to return the letter by a certain date, such as the 31st of December or 4th of January. I just wondered if that should be included.
I can add that. That's not a problem.
Thank you.
Brilliant. That makes sense, David. Lisa.
I know it was nothing sort of in particular. It was just to also sort of back that up that Courtham's, I think the surgery is the surgery that we get contacted about the most. So I'm not surprised, to be honest, that that hasn't improved. Looking at the contacts that we're getting about it.
All right. Yeah. Has anybody else got any questions or observations?
Yes, me, Caroline.
Hi, Michelle. Hi. Yeah.
Hi. Yeah, it was just about the whole content of it all. It's just obviously it's worrying, but I'm thinking just things like do not resuscitate and all of the other things that sort of test results and things like that. What's actually happening about contacting the patients that this involves? I mean, what are the next steps? I don't understand. We've been given the paper, but then what?
So what will happen is once we issue the breach notice, we will have meetings with the practice to make sure that the relevant guidance and the protocol are in place. And also CQC will be obviously from their point of view following up on the actions that they required as well.
I did notice in the report as well that it said that the people that had been missed have been made contact with. So I saw that throughout the report in relation to specific items. Right, I've got a few hands up. So I've got Emma, and then Karen, and then David. Is that okay? I'll let you have the final word, David. Yeah, Emma.
It was just to reassure committee, as you should be aware from the assurance standard operating procedure that's gone through committee before, we do have a primary care quality and variation group where we manage assurance of primary care contracts. Anything that comes through CQC, the practice are advised to put an action plan in place through the quality improvement plan, which Cotham have one active at the moment. That is supported by our team. It's got clinical oversight from the CCG exec leads who will offer some constructive feedback. What we can't give is assurance because we're not the regulator, CQC are the regulator, and it is obviously the provider's responsibility to action anything that CQC have picked up. But we do work with them and support them where we can to make sure that they are addressing the actions that have been identified from CQC.
Smashing. Thanks for that, Emma. David, Karen, your hand's gone back down. Are you happy to hand over to David? Yeah. Go on then, David.
Okay, thanks, Caroline. And yeah, I mean, clearly this isn't a good read. There's some things that need fixing here. I think there's a key line in the letter, though, in the middle of it, that we note that breach of contracts there, but it must be capable of remedy. So I think it's really important that we will, and the team will work with the practice to make sure they put this right, because it's not as if it's irretrievable.
Smashing. And then we've got an update there from Janice to everybody in the chat. So we'll capture that in the minutes as well. But a quick update to advise that Michelle Martin, the joint employee of the CLMC and the CCG Quality and CQC Facilitator, has a meeting with Cotham earlier in January. So they're reaching out for support with these matters, which is great to hear. Yeah, that's smashing. Thanks, Janice. Right, folks, yeah, are we okay with that then? So are we happy to accept the recommendations? So the recommendations are that we consider the content, which we've done, and to approve that we issue the breach notice in relation to the breach of Regulation 12 and 17 of the Health and Social Care Act 2008 regulations, and as identified by the CQC during September 2021 inspection. So people happy with that recommendation?
Yes.
Yeah, that's great. If we can move on then to item 61, which is the Mackenzie Group practice, and that's an update in relation to the application to close the Hartfield medical practice. And I think it's Emma, isn't it, that's going to take us through this?
It is, Chair, thank you.
Yeah.
So this report starts on page 68 of your pack. There's two items to consider within this report. The first one is an update on the engagement, which committee should be aware about following the October meeting, where an update was provided around the patient engagement already undertaken by Mackenzie Group about Hartfield in July and August. They are seeking to look for a permanent closure to the Hartfields branch. Following further advice from NHS England and from the Next Comms team, it's been decided that they would take a more collaborative approach for the next phase of the engagement, working with the practice and the CCG. There's an indicative timeline provided on page 70, where the engagement is going to commence from the 14th of January to the 25th of March. This engagement will be adding value to the previous engagement that's already been undertaken, and we'll look at possible scenarios and exploring what patients really want from the Hartfield site, looking at particular things like what services that they might want, what opening times, what their satisfaction is around current services, to look at not just whether it should be fully open or fully closed, but everything in between. It's anticipated that that might then lead to further consultation, but we don't know that at this stage. Healthwatch Hartlepool will be involved in this. There will be focus groups, face-to-face if possible. Patients will be contacted through any means that can, whether that's letter or text message. And it will initially be those patients that are registered at Wynyard Road and Hartfield. But all that information will be put either on the practice website and the CCG website. And the Audit and Governance Committee at Hartlepool are aware of this approach to this next phase of engagement. So that's the first issue, and committee are asked to approve the plan for this next phase of engagement and the indicative timeline, which has been set out around the ICS movement into the ICB and the period of purdah that might happen. That's the first part.
Actually, do you mind if we do it in the parts? Because it seems to make sense to have any questions about that particular part of it and accept the recommendations if people agree. Are you okay with that, Emma? Yeah. Yeah, brilliant. So has anybody got any questions for Emma in terms of the stakeholder engagement, the process and the timescales? Are you happy with it, Michelle? Yeah. Yeah, brilliant. Okay, well, if I can move then, that we're being asked to consider the update, and that's it in relation to that particular bit, isn't it? No, and approve the proposed collaboration, the collaborative patient and stakeholder engagement plan and the draft timeline. So are we okay to accept those two recommendations? Yeah.
Yes.
Yeah, lovely. Okay, that's great. And then if we can move on to the second part of it then, Emma, that'd be great.
Yeah, thank you, Chair. So the second issue is around the temporary branch closure. There was an update provided at the last October committee on the back of the independent infection prevention and control report that has now been, and that was the item in the minutes to be picked up. That is now provided on page 74 of your pack. And that was from the infection prevention control team at North Tees FT. There were some outstanding issues which prevented a decision being made on the temporary branch closure at the last meeting. And just to summarise, those outstanding issues were around a waiting room door that's been confirmed can now be kept open because the fire policy has been updated accordingly, and that's to aid with the airflow to the practice. There was some confirmation required around the air extraction system, and the ventilation has got the minimum, it's got more than the minimum requirements of air change cycles. So that is deemed to be sufficient ventilation. There's been confirmation that the social distancing requirements in place for primary care should be 1 metre, where possible 2 metres, but the minimum is 1 metre, and that's the infection control guidance that's just been published on the 17th of December, which continues the fact that we need to have the use of masks for patients and staff. Screening takes place for COVID, triage where possible, including any segregation of patients who've got respiratory or cough symptoms, the use of the lateral flow testing, infection control procedures such as hand hygiene and PPE, and the 1 metre social distancing. So that's in the 17th of December IPC guidance. And then the final query was around a window in the consulting room that the practice felt they couldn't open due to confidentiality reasons because it opens onto the path. We've sought clarity again from the IPC team who helped with the report, and has said that it would be adequate enough for that window to be open in between patients and in between clinics. Their advice, therefore, is that they feel that there is sufficient infection prevention and control procedures in place that do not prevent the practice from being open. Therefore, the recommendation would be that the branch site is reopened. Bearing in mind the booster programme and the priority that has on at the moment, the recommendation that this would be for the 10th of January for it to reopen, to allow the practice to actually mobilise the staff back and put the rosters and the appointment booking system back in place to facilitate that.
Brilliant. Thanks very much for that, Emma. Obviously, I've read the report, and it all seemed to make sense and seemed doable. So, have anybody got any questions for Emma or any observations that they want to make before I go to the recommendations? David.
I was just wondering whether there needs to be some rider assuming staffing levels are adequate, as being, I think we're all aware the Omicron is highly infectious, and other parts of the country are already suffering from a loss of health staff being on sick leave at the moment. I mean, hopefully that won't affect that particular practice, but I think we are all aware of that. So I think the probably just before sort of maybe there should just be some condition assuming that the practice is able to staff it due to its staffing levels or something like that.
Yeah. Karen, are you going to respond to that, and then I can see Jean's hands up?
Yeah, we would consider that as we do with any practice. Obviously, we have received branch site closures in the past in relation to staffing levels and the COVID infection rates and their ability to staff branch practices. We would expect that as we're reopening, and the recommendation, should committee accept that, is to reopen this branch should the staffing levels in the practice impact this practice for a branch or any other practice, that in line with our current guidelines, it would make a further application to close that branch. As you'll be aware, committee have delegated the authority for branch application closures to myself as Director of Commissioning in the eventuality of such circumstances. So we would continue under that same process for reassurance to the committee.
Brilliant. Thanks, Karen. Jean?
So just to reflect on comments of both Karen and David, I think it's important that we are careful with our use of language, because adequate staffing levels is something that is very much open to interpretation. And as Karen said, the guidance that comes out nationally can vary, because we're in a level 4 EPRR status, and therefore what would be considered appropriate one level may change. So just to support what Karen said, that in conjunction with national guidance, recognising that may change from time to time depending on the status. So I think we'd have to be careful about the language that we used, because adequate is very, very variable in terms of interpretation. Thank you.
No, thanks for that, Jean. I think obviously if we do agree to reopen this branch site, then obviously it'll just fall in sync with all of the other practices across the patch, which may or may not be affected by by staffing levels and the new variant. We'll have to see how that rolls out. So people feel that they've had enough opportunity to ask questions, make observations. If I move to the recommendations, is that okay? Yeah, So I'll take the recommendations one by one. So obviously we've considered the additional information provided, and as a result, let's have a look. Sorry, folks. As a result of the request from the Mackenzie Group to extend the temporary closure due to the COVID risk assessment concerns associated with the updated infection prevention control guidance. So we've considered that, and I think we've given that due consideration. We've been asked not to support the further extension of the temporary closure, and it's been suggested that we reopen the branch. So are people happy to do that? Yeah, everybody's nodding. That's great. But obviously in relation to the accelerated COVID vaccination booster, we're talking about reopening it from the 10th of January to allow the practice to mobilise the appropriate staffing structure and facilitate the reopening. People happy with that? Yep, okay. David?
Yeah, Karen, I just think we need to emphasise Karen's point really, that I know that's the recommendation for us, but I think we should just stop at saying we expect it to open 10th of January. And then if they can't, then they need to come back and tell us that they can't.
Yeah.
Rather than just not just put the recommendations straight into what we say at the practice, if that makes sense.
Yeah. Okay. Yeah. That's smashing. Okay, lovely. Well, with that then, I'll move on to item 62, and that's the COVID-19 response update. Is it Emma that's taking us through this? Yeah. Over to you again, Emma, then. Thank you.
Yeah, thank you, Chair. So this is the COVID response update that committee should be familiar with. We provide one every meeting. Page 80 offers you a reminder of the previously agreed temporary branch closures that we did have in place and the ones that have now been partially opened or reopened to support either core GMS services or the vaccine. There's been no change in section 2.2 to the CCG support offered to practices with regards to the local improvement scheme, the extended hours days or the repurposing of GP improved access. I'll jump about a bit. Section 4 gives you an update on the COVID vaccination programme. The main change to this paper is in section 3, and this is to do with a temporary list closure. On the back of practices reporting their operational escalation level of pressure, the Endeavour practice in Middlesbrough applied for a temporary list closure on the 11th of November for a 12-week period. Now, whilst the regulations don't allow for an informal or a temporary list closure place, there is a process set out in the NHS England Policy and Guidance Manual, which is a published document, to offer an interim process to support practices, because there is a recognition that unprecedented levels of demand can lead to pressures in practice, and they can therefore apply for a temporary list closure. We have followed the process set out in the Policy and Guidance Manual and the process set out in the NHS England's North East and Cumbria variation policy document that has previously come through committee, I think last year. Because of the quick turnaround, because this is a process on the back of an unprecedented pressure, there's been quite a quick turnaround for this. Primary Care Operational Group made the recommendation to the Director of Primary Care and Community Care for a decision to approve the temporary list closure. Therefore, committee is asked to ratify the decision that was made, but also in the line of being able to expedite these requests and to meet the turnaround time as set out by the NHS England variation process, that the committee continue to allow delegated decision making to the Director of Primary Care, with the recommendation coming through the Primary Care Operational Group, and that future decisions are ratified at future Primary Care Committee meetings.
Yeah. Okay. Has anybody got any questions or any observations for Emma or any of the team? Karen?
Yeah, it was just to point out, Chair, as with any delegated commissioner, any delegated decision making that's made to myself as Director of Primary Care, should timescales allow for us to bring it to committee prior to a decision being made, we would do that, as we would for any other decisions that the committee dates allow for. So it was just to reiterate that point. that it's just not determined automatically that a delegated decision would be made if we can get it through committee in the timescales.
And I'd just like to assure the committee as well, myself and Karen are in regular contact. So if there is anything, we would have a discussion about it as well. So is everybody happy with that? I will go through the recommendations just for the minutes, but are we? Obviously, we're noting the content of the paper, and thanks for the paper, Emma, because it is really useful to see how it's evolving over the period. I think it's a good public record, and we're going to ratify the decision made by the Director of Commissioning, Strategy and Delivery, Primary and Community Care. Some titles in here on the 16th of November, which was about approving the informal temporary list closure application for the Endeavour practice for 12 weeks up till the 11th of February next year, and to approve the recommendation to continue with the process to expedite informal temporary list closures requests directly through the Primary Care Operational Group to the Director of Commissioning, Strategy and Delivery, Primary and Community Care, and to report to this committee for ratification, sometimes retrospectively. So are people okay with that? Yeah. Lovely, that's great. So with that, then we're going to move on to the items on the agenda that are for discussion, and that takes us to item 63, which is Hannah, who is going to take us through the budgets.
Thank you, Chair. This is a bit of a first. We normally have a written report that we go through for PCC. However, we haven't done that this month due to the fact that we would have been bringing Seven's financial report, and at Seven we didn't actually have any budgets for the second half of the year, so it would have just looked incredibly ridiculous with half our budget being missing, and it wouldn't have made a lot of sense. So we haven't brought that because it would have been a complete waste. We have only just finished month 8, and that was has been finished since the cutoff for this meeting, but I can go through sort of just an overview really of for month 8, and that is with what in each 2 budgets being added to the allocations. We obviously in 8.1 we will add £1 million deficit on primary care delegated budgets. For the first 6 we have another £1 million for the second 6 months. So in all, now looking at when we do is a £2 million deficit around delegated budget, and obviously this is on a wider scale throughout the sea.
Hannah,
I think probably that's the main headline from a financial point of view. Oh, I'll tell you what I'll do. I'll turn off my incoming camera.
Oh yeah, thanks, Hannah.
Can you hear me now?
Yeah, it's a bit Dalek-y. I didn't know. I thought it was just me, but I can see
that's
a few.
My lovely Wi-Fi. I've turned off all your cameras, so I can't see anybody now. But that hopefully will help with my Wi-Fi. Is that a bit better?
It is. It's loads better. Yeah. Everybody okay with that?
Right.
Heads nodding. Yeah.
Okay.
Lovely.
Marvelous. Thank you. So I don't know what of that. I don't know what you heard of that. Do you want me to run through the highlight again?
If you could, that would be great. Yeah, that'd be smashing.
Hannah, we heard that's the main headlines, and that's it.
Yeah, that is really the main headlines. I mean, obviously, it's a depressing place to be for delegated budgets, having a deficit position. It's the first time we've ever had anything, of this size, and that comes down to the allocation that we're given for delegated budgets against the contracted spend, which, for the majority of the spend that we incur, it's a general national contract. There is, you can't negotiate it. It's a set amount. So there's not a lot we can do about it. Obviously we have raised the issue of the allocation further up the line. We are not the only CCG that find ourselves in this position in the North East, where our general spend is more than what we've got as an allocation for delegated, and that a lot of that comes back to over the last couple of years, the growth that we've been given not being enough to actually cover the growth that's been put onto the contracts, and we've seen this sort of gap get bigger and bigger. But I know, like I say, and there's probably Mark will come in a minute and maybe want to add a word or two, but you know, this is getting managed across the wider system basically. I don't know if Mark, if you want to add anything around the financial overview. Yep.
Yes, I will. Thanks. So thanks, Hannah. You're right. So we had a deficit in the first half of the year, which we reported through up until month 6. We then have a similar deficit arising in the second half of the year plan. But as Hannah says, that's being managed as part of the wider CCG overall position. There is a challenge in terms of the allocation we receive and the commitments we've got against that. But the reassurance really is that it's managed as part of the wider CCG position in the current year.
Smashing. Thanks for that, Hannah. Thanks for that, Mark. Has anybody got any questions or observations that they want to make or ask? I've got something in the chat. Oh, that was just Caroline saying that she was struggling to hear. Yeah. So are we happy to receive that report then? Yeah. Yep. Okay. That's smashing. Thanks for that, Hannah.
Thank you.
So if we can go on to item 64, which is the primary care networks and the transformation report, and Rebecca's going to take us through this particular report.
Thank you, Chair. Okay, so the purpose of today's paper is to provide an update in relation to primary care networks, the contractual updates, and also some of the ongoing developments with our PCNs across Tees Valley. Just to give you a bit of background, NHS England advised in August 21 of a number of new PCN requirements that were due to commence in October. That letter described the introduction of new service requirements and also additional funding that PCNs would earn through the second half of this year and also into next year. Committee should note that further to the paper being written for presentation today, additional variations to the requirements have occurred, and that's to free general practice up to help further drive forward the COVID-19 booster programme. Therefore, some of the elements that the PCN contract would have been implemented from October have been paused. For example, some of the additional investment and impact indicators that were due to be implemented, which will now be income protected, and also the transfer of the CCG extended access service, which was due in April, is now delayed until October 22. Okay, so in terms of key changes and updates, there's 2 new specifications that commenced in shadow form from October. One is around cardiovascular disease and prevention, and the second one is around prevention and tackling neighbourhood health inequalities. In relation to CVD, the CCG intends to work with the PCNs to explore their support requirements and also the progress to date through the development of a self-assessment template, which we'll share with PCNs in Q4. And with regards to population health and tackling health inequalities, the CCG has recommenced our work with PCNs regarding population health, establishing workshops with PCNs, directors of public health and the system experts to support the PCNs to identify the priorities and intervention for the chosen priority. And it should be noted that PCNs will also be provided with some one-off non-recurrent funding to help embed this intervention. Just a few updates in relation to existing specification requirements. In relation to social prescribing, a self-assessment has been completed by all PCNs to identify progress to date in relation to the workforce and the services provided to patients. And that will also be helping us to inform the personalised care specification, which is due to start in April 22. In relation to the requirements for extended hours, as Emma noted in her paper, we have allowed a relaxation of those requirements to repurpose the hours in and out of hours to support the vaccine programme, and that will remain in place until the end of Q4. Just to give a bit of an update with regards to workforce, the PCNs continue to increase the workforce through the R scheme. All PCNs met the requirement to submit a workforce plan in August of this year and also October to provide indicative plans up to 23-24. And the paper shows the increase in the whole time equivalents during this year and also planned up to Q4. Just a few things that I wanted to draw out. So as of March 21, there were 104 whole-time equivalents in post, and it should be noted that in March 2020, that was 19.78, demonstrating that PCNs continue to make use of the R scheme to employ the roles and also create additional capacity in general practice. By the end of Q4 of this financial year, PCNs have an aspiration to employ 278 whole-time equivalents across the 14 PCNs, and particularly the roles that the PCNs do seem to be recruiting most often to is social prescribing, pharmacy posts, physiotherapists, and the mental health practitioners. The CCG also recognises one of the key constraints to recruitment is the estate's capacity to house the additional staff. And to this end, we funded expert additional support to PCNs to write estate strategies, and they're due for completion in Q4. So just in summary, in regards to the next steps, we continue to support the PCNs by holding monthly CD meetings. They bring together system partners and also to look at tackling common issues and ongoing support. We'll continue to help with the population health and inequalities work. We will implement the findings of the estate strategy work and also the selection of the Tees Valley CCG for an advisory audit in Q4. And then finally, we'll continue to work with PCNs regarding the reintroduction of the IIF indicators and also the additional specs which we expect in 2022. I just wanted to also obviously say publicly thank you to the PCNs for their ongoing commitment to the vaccine programme, which has of course been a tremendous effort over the last 12 months, and that's been despite continuing to develop their ongoing ways of working of networks and also within the wider system. Thank you.
Brilliant. Thanks for that, Rebecca. Has anybody got any questions or any observations? I've got a few hands going up there. I'll go to David Emmerton first, and then Karen, and then Dave.
Thanks, Becky, for that report. Very interesting and very encouraging. Just wanted to ask a little bit more about workforce planning. And I realise there's some overlap with the next paper in terms of risk, particularly for medical staff. And just wondered whether PCNs and or CCGs have got an understanding of what retirement of present GPs is likely to be over the next 5 years or even 10 years, whether that data is available to help sort of plan future recruitment of medical staff, both for maintenance and hopefully for increasing workforce, whether that is information is sought and available.
So the primary care networks, obviously, they have to submit their workforce plans as a network, and individual practices have to do that also through the Strategic Data Collection Service. We work closely with the Training Hub as well with regards to future retirements, but that's certainly something that we can consider as we move forward in order to gain that picture. Karen, I'm not sure if you would want to add anything in addition to that.
Yeah, there is a piece of work being undertaken currently across the ICS, David, in relation to workforce and looking at how we build the wider workforce and have a particular focus on primary care. We're also working with the Training Hub in relation to GP resilience and making sure that we're working with them particularly around workforce, and that baselining will be done locally. There is work happening at an ICS level, but will be working with the Training Hub to do that locally to make sure we're clear of the future requirements. And as you know, the Training Hub consists of a number of members, and Janice is on the call as well as an LMC. And I think it's right to say all partners have a really clear focus on what do we do over the next few years to ensure the sustainability and the recruitment and retention, working with Health Education England around GPs and the wider GP workforce. So that is in train. Thank you.
Dave?
Yeah, thanks. And thanks, Becky. I just want to amplify something you said there in the report. The progress and the achievements made in the report are remarkable anyway, but remarkable considering where practices have been and the challenges with COVID. So it's credit to the networks and the people in them, but it's also credit to CCG and LMC colleagues who've been supporting them. So thanks to everybody for that, because it's you could understand if the progress had slowed down. It doesn't seem to have slowed down at all. So hats off to everybody for their input into that.
Yeah, if I can just reiterate that as well, Dave, because I think that's really what strikes me. Obviously, we were doing all of the PCN stuff before the pandemic, and there was a lot to do at the front end of it. But how they've been able to mobilise and respond and still do all of this stuff alongside it is just absolutely incredible. So again, thanks go to the CCG staff, but also to the PCN networks as well, because it is incredible to see when it all comes together. And for me, there was quite a lot of optimism in the report, seeing how it is rolling out, and the increase in numbers, and some of the new posts I think are quite exciting. I see quite a lot of them advertised, and it does seem to build up some optimism around it. So it really does gives us a bit of hope for the future. So thank you very much, folks. So if we can, the recommendation was simply to receive the contents of the report, and to assure the committee. So is everybody happy with that?
Yes.
Yeah, lots of nodding heads. That's great. So item 65, and that's the primary care risk overview. And Karen's going to take us through this.
Yeah, so committee members will be familiar with this paper as we present it at committee over a number of occasions. The paper itself is a brief update to keep committee appraised of the risks that are currently on the risk register. There have been no significant changes since we last presented this paper around risk since the prior submission, although the actions and our assurances have been updated to reflect the current position in terms of the work that's been undertaken. So without going into lots of detail, as committee will be cited on all of the risks that are on the register, the committee is asked to have reviewed the risks, which I'll assume that everyone has done. Consider any areas that you may feel necessary as a primary care committee in relation to a deep dive, and then consider any additional risks that you feel may need to be added to the risk register that we haven't already presented. So that was very brief, Chair.
No, that's absolutely fine. I think what's good about this particular report is because it comes so regular, people are really familiar with it now. So I feel that it's really embedded into the process. Has anybody got any specific questions that they want to ask Karen, or has anybody got any observations that they want to make? As she said, there's nothing that's changed significantly since the last one. No, that's lovely. People happy to accept the recommendations as set out in the report? Yeah, lovely. That's great. So the next item then is item 66, and this is the GMS contract update, and Culvey is going to take us through that one. Over to you, Culvey.
Thank you, Chair. The paper provides a further update to previous summary presented to the committee last year, which sets out the key changes to the General Medical Service contract for 2021-22 to 2023-24. It's an update to the 5-year framework for GP contract reform to implement the NHS long-term plan, which was published in 2019, as well as the NHS GMC contracts and PMS agreements amendment regulation, which was published in October of this year. The areas where the contract changes were made but were not limited to are prescribing and dispensing, online and electronic services, certificates, and the time limits in relation to transfer of patient records. The regulations also stipulated a requirement for the disclosure of information relating to earnings. However, last month, the Secretary of State issued a statement delaying the implementation until at least spring next year. As of the 1st of October this year, NHS E&I stood down the pandemic regulations, which resulted in practices reverting back to 1 appointment per 3,000 patients per day. The NHS Friends and Family Test revised guidance were due for implementation in April 2020, but is currently on hold. Earlier this month, NHS E&I published a letter regarding temporary changes to supporting COVID-19 vaccination services, including QOF, Investment and Impact Fund, and wider measures, of which further details can be found in the paper. NHS national team have not yet published the contract variation to the GMS contract, PMS and APMS agreements, which means that the regulations published in October 2021 will not take effect until 14 days of the variation being issued to the practices. The committee is asked to note that the national negotiations regarding the contract between NHS England and British Medical Associations are still ongoing. Thank you, Chair.
Smashing, Culvey, thanks for that. Has anybody got any questions or observations? An awful lot of content there to go through, particularly with all of the attached documents as well. Has anybody got anything that they want to ask or observe? No, like I said, it is for information. So people happy to move on to the next item then? Yeah, lots of head shaking. That's great. So the next item is item 67, and it's the plan for improving access and supporting general practice winter access fund overview and update. And this is Emma, I think, who's going to take us through this. I'm so sorry for the number of knocks at the door. I've had about 2 people knock at the door this morning, and since I've been on this meeting, there's been 4 knocks at the door. Stuff the kids' Christmas presents now, they'll have to wait for them. Emma, is it you that's going through this one for us?
Yes, it is. Thanks, Chair.
Over to you, Emma.
So this has been provided for information, I think, following the brief update that was provided at the October committee, and there was a request for further detail around the plan. So our plan for improving access was published by NHS England on the 14th of October, a copy of which is being provided in Appendix 1. And it relates to the £250 million nationally that's been made available for the Winter Access Fund. I will stress that at the time of writing the report, this was accurate. Members of the committee might be aware that things have changed significantly since the Prime Minister made his announcement a week last Sunday. The Winter Access Fund was designed for increasing and optimising capacity, improving access to urgent same-day primary care, and to increase resilience of the NHS system over winter. The timeline, which is set out on page 134, you'll appreciate was quite tight in terms of the date that the document was published and the date that plans were required to be submitted. It also outlines in that timeline the process that the CCG approached to engage with everybody. We tried to engage with all 80 practices that we cover under Tees Valley CCG, the 2 local medical committees, the GP federations, and the PCN clinical directors in order to shape the plans that we submitted to the ICS region. And there's an idea of some of the plans that have been provided. We are still awaiting the final confirmation from NHS regional team in terms of the next steps. The guidance that's subsequently been published nationally around the COVID vaccination booster and the priority that should now take. There is still the line in all of that public documents that the Winter Access Fund is still available for practices and systems to use where it's going to increase and optimise capacity, although it's not to be used to supplement the funding made available for the vaccination programme itself. So the CCG is still progressing with the Winter Access Fund along the guidance that we are given by NHS England, and that's probably as much information as I can give at this stage.
That's smashing, Emma. Thanks very much. Again, I just think the your ability to be able to turn around stuff like this and the capacity to be able to turn it around in such tight timescales is incredible. Has anybody got any questions or any observations for Emma? No. No, that's smashing. Like I said, I think it was a good report to read to see all of the different things that are ongoing. Well, it'll be interesting to see how it rolls out with the new variant. Got Janice has put a question in the chat. In the timescale details, it mentions the LMC pausing discussions. We have since written to the CCG to advise that we're engaging in discussions of we have taken the lead from our local practices rather than the national directions, and we will continue to do this. Thanks for that, Janice. Yeah, that's smashing. Well, that report was for information. So with that, I'll move on to the next part of the agenda, which is simply items to note or any other business. I haven't been notified of any other business. I doubt any's come to light over the last hour. No, okay. That's smashing. Questions from members of the public. Nick, have you got anything that you'd like to ask us? Is Nick still on?
Yeah, nothing from me. Thanks for that, though. Cheers.
No, thanks, Nick, for attending. And then consideration of any impact on the risk register. Well, I think we've gone through all of that in the risk report, so there's nothing new to add other than what's already there. And then the next item is key items and decisions to report back to the next governing body. So myself and Karen normally pull together a report that goes to the governing body, just updating them on what we've been discussing and any key decisions that we've taken. So with that, I just take this opportunity to wish you all the very best for Christmas and the new year. I hope that you manage to get some respite over the Christmas period. And our next meeting isn't till the 15th of February. Venue to be confirmed. Wouldn't it be lovely if we could do have our final hurrah at North Ormsby? Wouldn't that be lovely? I'm not feeling it, mind you, but it would be lovely if that was the case. So Dave, you've got your hand up. Would you like to say something?
Yeah, it's just a thought. So the last meeting we've got schedules in February, but given the change up to ICB, ICS, we might want to think about having a closed down meeting in March, and that probably goes for a few of the committees. We'll just need to think that through, and that might give us more of a chance to have it face to face than virtual. You never know.
Yeah, I was wondering that actually. I wondered if we'd be required to do some things in April actually, just to close it down properly and pass over.
Yeah, we'll need to have a look at that. I think it would be worth considering anyway. So.
Yeah. Okay, yeah. That's smashing. Well, I think just for people, if you can get dates in the diary, even if they're provisional, that would probably be helpful for people. So that would be lovely, right? So if I can just take this opportunity, like I said, to wish you all the best for Christmas, and I'll see you in the new year. I'm just wondering, for those that are going on to the in-committee meeting next, are people happy to do that at 3 o'clock rather than 3:30? It's scheduled for 3:30 till 4:30. People happy to jump on? Yeah, if I say 3:05, and it'll just give people a chance to have a comfort break. Okay, so I'll see you at 3:05. Okay, folks. Cheerio. Bye. Bye.
Thank you.